to the extent you have questions about what CCR is and detailed questions, we hope you will join in and get them answered along the way. We don't have all the answers. We think this as a group will have an awful lot of the answers, and hopefully we will find the people who have the answers that we don't have and develop them together, because this is really all about collaboration. Let me introduce Frank DeGree, who most of you know, who just ended his 22 years as chairman of the Family Medicine Department, to kick us off and talk about some of the principles that are driving us. Frank?
Thank you, David. Good Lord. Hello, everyone, and thank you for being here. Please remember to keep yourselves muted if you're not holding the talking stick, because this is a lot of folks to manage the airwaves with. So what I thought would be appropriate and useful for me to do right now is just make a few comments about principles and priorities and the purpose of this thing, and there will be some hints tucked into that as to what I see as my role here. Normally we just put our heads down and do our jobs, and we can on most days with a tailwind when the sun's out, we can get away with that. We just do what our job descriptions say we're here to do. Not today, not these days. We have an opportunity to create something new under the sun. This is a window of opportunity that's going by. And so we have to reach through and take a hold of an opportunity that has emerged in part because we're fresh from having our noses rubbed in the fact that we're not up to the task of managing major crises, and we already know as a steady background drumbeat that even at our best, many of the people that we purport to serve go unserved. I don't want to be too harsh about this, but we're not fully succeeding at our jobs. And I think we have an opportunity because of
Can you come in real quick?
Sure.
This is our workers.
Can we get a mute around the room? Anyway, we have an opportunity to do something very interesting right now. And as David said at the very top, this will essentially be doing what we're already doing very well, but doing it together in a way that we haven't done before. So let me just outline a couple of what I think are our principles here and some of the headwinds that we're likely to hit. I think it's really important for us to remember that we're here to serve people in their families and in their communities. That's our job, not to feather our own programs or our own agencies. We're here to serve others. And it's so easy to forget that. I have to remind myself of that all the time, that our mission is service to those who need our services. And the vision is creating a means by which it's easier to do that than it is to not do that. So we'll need constant reminding. And one of the people who will constantly remind you and myself that we're here to serve people in their families and communities will be me. And I think we will need to measure everything we do against that. Another principle, all of us are better than any of us. When we work together, we're better than the best of us. Working together is an extraordinarily powerful operating principle. When done well, it produces something new under the sun. And so that's one of the things that we'll continuously be struggling to do. And so it's a core operating principle. It's a core operating principle of this entire CCR enterprise. Another principle, that is hellishly difficult to do. Collaborating across our various programs and agencies and agendas is incredibly difficult. And the more of us there are, there's a geometrical, there's a sort of a geometrical lift in complexity there. And so I think one of the things that we're going to have to do in order to accept the changes in our workflow and the changes in our priorities in order to accommodate each other is to introduce a layer of overhead in our work that is essentially a cost. There's an overhead associated with collaborating, with integrating our work to accommodate each other. We have to, we're going to be bumping into each other. That's the nature of complexity. And that hurts us. That causes us to slow down. So there's a cost associated with doing this for what we trust will be a higher or a greater benefit. Now, I'm going to focus a lot on that cost because what I notice when people try to collaborate and integrate their programs and themselves together is they get discouraged at the cost and lose sight of the value. But there are ways to manage this. And what we're going to try to do here in acknowledgement that it takes time and that it takes money and that it takes formal structures to create and maintain integrated communication with each other is we're gonna actually build explicit structures, and we're gonna have more or less continuous reminders of how we're giving up a little to gain a lot, and in the service of the people that we're trying to serve. We're going to make sure those structures are flexible so that it remains easier to work together than it is to work apart. Well, this is a complex system, and flexibility. Life is a beta. This whole thing is a beta test. None of it is written and rigid and final. We're making this up as we go. We're creating structures. We'll go, aha, that's it. That's what we'll do. In parentheses, for now, that's a beta. So we need to remember to retain our flexibility and our softness to ever appearing better solutions to the problems that we're trying to deal with. We're going to have disagreements. We're going to have sharp disagreements around principle. And I, for one, believe that is one of the singular healthiest phenomena that can happen when we try to work together. So one of my jobs will be to, when I see differences of opinion, which I call conflict, to surface those differences and process those differences in a way that is not ad hominem and that is grounded in remembering our pole star and remembering who we're trying to serve so that the best solutions can emerge and so that we can retain enough softness and respect and appreciation for each other so that we can commit to the best solutions, even if they aren't our precious solutions that we ourselves brought to the table. You know, I think the real world here, the real payoff is not us. It's not the people that you're looking at on your big checkerboard on your screen right now. It's people who live in communities who we purport to serve. So the real payoff and the real work happens in communities. And we need to essentially be a kind of funnel that funnels our resources and our experience and our expertise and our networks into an effort that serves local communities. And we need to create in those communities a sense of agency and ownership that is not ours, but is theirs. We need to create among those communities a linking and a network. We want to create learning communities of communities, just as we ourselves want to create teams of teams. So we'll need to continue to get a read on that and learn what the effect of our efforts are in communities on the ground as we go. And finally, there's a lot of work to do. And some of it we just need to get doing. So it's real nice to hear hot air from me and to create structures in the sky and all of that. But we got work to do. We need to roll up our sleeves. We're going to create here a team of teams. There's going to be a set of teams that work closely and purposefully toward serving our communities better in one or another facet. And those teams will need to work together as a team. And we really don't want to be hasty and do things without making sure we're looking at the pole star and making sure we've got our priorities and principles straight, making sure we're talking with each other. But we can't waste time creating elaborate structures. We've got to get going. People are dying out there. And we've got to make sure as little of that as possible happens. So those are the operating principles. I see myself as something of a guardian of the process to the extent possible. This is a big group to manage process. And to try to, I guess you'd say, keep David out of trouble because he's a rabbit. He'll run off and do stuff. I wake up in the morning and my inbox is full of 16-page documents. So we've all got a lot of work to do. God bless you for being here. I'm really looking forward to getting to know some of you who I only know by reputation, but not personally. I'm on my way to doing that. I think this is a beautiful thing we're trying to do. And if we keep our sights on our pole star, even our failures will be beautiful and will be successful. So welcome and thank you. And I'm going to get out of your way for a moment and turn the talking stick back over to David.
Thank you, Frank. Frank said something the other day that stuck with me, which is that we usually approach the people we're trying to help, trying to coordinate what it is that we have to offer, as opposed to approaching them and seeing what they need. And what this is all about is figuring out how we can help people who need help and how to give them agency, not advance the particular piece of the pizza pie that we have. In order to do that, what we're trying to do is to attack the fragmentation or overcome the fragmentation that naturally exists when you have a behavioral health program and a primary care program and a public health program and this program and that program, to try to create a common infrastructure, human and technical infrastructure. That only works at the local level. And so all of this is about finding local leadership, supporting what's already there, building on what's already there, building on what's already in the states at the state level. But we're going to try to get going on that with some activity teams. We're also pursuing resources, so this isn't all volunteer. But as Frank said, we don't want to wait. So Ashley Brown has been a leader in this from the Colorado Health Institute. She and my colleague Kyle Leggett are going to describe what we're trying to do in terms of activity teams. By the way, Jason Greer can copyright that name. It was his idea. But we ask each of you to get involved with one or more of those or pieces of one or more of those as appropriate. Ashley?
Hi, everyone. I'm Ashley Brown at the Colorado Health Institute. Thanks for the introduction, David. And we are going to talk a little bit about activity teams. There's a team of teams, as Frank mentioned, and there's going to be a lot of teams, but we're starting with just a few to get started. The things that we think are most important to get up and running as soon as possible. And the one that I have volunteered to lead is focused on finance. And this really goes back to what Frank was saying earlier about the cost of collaboration. And I've had the pleasure of working with many of you on the phone, so you already know this, but for those of you who don't, my previous experience is with the state innovation model, the regional health connectors model, and other collaborative models. And so I've experienced firsthand over the years the challenge of getting this kind of work funded. It's traditionally been funded through grants and then not sustained by any sort of operational, long-term, sustainable funding. And that's something that I truly believe that we have to change if we're going to actually change the way the system serves individuals and families. And as long as we continue to fund this sort of by piece grants that don't really have great sustainability in place, the more we're going to find ourselves in rooms like this where we're trying yet again another initiative where we have maybe a big bolus of funding for a short period of time. We're going to do something great. We're going to prove it works. And then it's going to go away because the grant funding ended, right? And I'm seeing some nods on the phone. So I think a lot of others have also experienced this. And when David and I started talking about this idea about 6 to 9 months ago, this was the thing that I was most passionate about. I said, David, all of this sounds great. How are we going to fund it in 2030? How are we going to fund it in 2040? I recognize that we have a ton of money coming into the state right now. That money is not going to last forever. And if we're not thinking about how we fund this long term now, then we might as well not even waste our time, because I'm done working on one-time grants that just go away, even though we've proved that good things can happen when we have that money. And so that group is going to be really focused on that question. How do we build this into payment models? How do we leverage state infrastructure investments? How do we figure out how to braid and blend the private and public funding that is available in the long term to support this kind of complex systems change? This is one of the things that we have not figured out by any stretch of the imagination. So I welcome all of you to join that group and help us figure it out. I don't have the answers. I just have the passion and the time to help try to facilitate those conversations and move us towards that direction. So that is my activity team. I would love to have you guys join. And I'll pass it off to Kyle, who I think is going to introduce some other activity teams, and maybe Jason as well.
Yes, please.
Great. Thanks, Ashley. And I am actually not going to be the lead on any activity team, so I'm going to go through the remaining 4. You all should have them in your agenda as well. And then maybe if Aaron or Jason want to talk a little bit, or David, about specific activity teams they'll be leading, but just to give you all a little sense of what the other groups are. So we have finance as one of those key activity teams. Another one is going to be working on the actual model itself. So, we're talking about this commons model, and we know that we have a good working framework for this model, but we need more. So we're going to have a commons working team led by David and Leslie Brooks that really dives into the idea of whole person, whole family integrated care, how to have community level activity to promote thriving. Things that come to my mind right now in COVID are vaccinations, but we're also thinking more generally about daycare, exercise. What is it that actually promotes thriving in a community? And then we are going to have an IT activity team that really is looking at, well, how do we complement or back up our human infrastructure, the commons, with a state level, family and person oriented IT or technical infrastructure. And Jason Greer is going to be leading that. If I say that, Jason, and you haven't agreed to it, please feel free to, all of a sudden do this or something. In addition to the IT activity team, we're going to have a policy communications and development activity team. I will be joining that activity team, but it will actually be led by Aaron Silver, and it's going to be focused on how do we communicate with our state officials and the groups who are involved in state level policy decision making. And some of that gets at the ARPA funding and other federal and state dollars that are available to us. How do we talk to our legislators about this? But then in addition to funding, how do we also get state buy-in outside of this one-time funding opportunity? Additionally, we'll be talking about our public communication about the CCR, the Collaborative Community Response Model, and also be working with local, state, and national foundations and agencies. And then we have our kind of community leaders working group, which is really about how do we recruit leaders in the communities to lift up and support the voices of the most important members of this entire enterprise, which are our community members. And we don't want to lose sight of that, as Frank mentioned, kind of our North Star. Who are we doing this for? Who really matters? And so within that, it sounds like potentially Mark Wallace, Leslie Brooks, and Peter Mineta either have been considered for those roles or maybe have volunteered. I'm not actually certain at this point. But we have these 5 activity teams. They're in the agenda. I'm going to also put them into the chat, so anyone who maybe doesn't have access to the agenda can kind of see those. And we're asking for volunteers to help fill out those activity teams to move us forward, to go from a small group working on this with many, many, many conversations to a few strong working or activity groups or teams that are doing the work that we need. And this is a better version than me putting things in the chat. So thank you for sharing, Linda. And maybe if
Jason,
any of the...
yeah,
Yep,
Jason, could you describe the IT police, please?
Sure, you bet. Thanks, David. Yeah, hi, I'm Jason Greer. I'm the CEO of CCMCN. I've been working with the FQHCs and safety net community organizations for about 20 years here in Colorado, and we've and I think it's just important to point out that, like, as you're getting into communities and talking about community integration and bringing communities together, the technology space is also very much a community. It's equally as complex when it comes to the relationships and needing to really respect the technologies that exist and find ways to make them all kind of work together in a coordinated way. In the same way that communities are maybe self-criticized about being fragmented, technology is also equally, if not more, fragmented across the state. And so we're looking for ways to kind of bring that together so that we can have a kind of a unifying structure essentially across Colorado. I've been presenting on this concept of a unifying structure for the last probably month or so in a few different venues, and it's being received well as something that's needed. But at this point, the next step is to bring groups together to try to figure out what's the best way to kind of create a unified architecture. I actually describe it as a community outcomes architecture because it's one that takes the best of the best that's out there and then finds ways to make them all interoperable and finds ways to make them all targeted towards very specific outcomes, and of course targeting whole person family care. When you think about the technology space, really quick, just want to paint a picture for the space that we're working in. You know, you've got local technology like Boulder County Housing and Human Services has Boulder Connect, and Jefferson County has a version of that called GenApp. You've got regional technology like what QHN has with their HIE and CRN platform, and Correo has on the Front Range, and other parts of the state with their HIE and other tools. You've got clusters like CCMCN has across the FQs and the Rural Health Network and across the Northeast Colorado in our support for Dr. Wallace and Ray Region 2. You've got innovations like the CRISPR system and the CORDS network, other things that are all out there that need to be all brought together and enhanced across some kind of a unifying strategy. Then, of course, you've got your statewide strategies, of course, with OIT and HMIS and CDPHE and Civic, and your national players, right? So you've got really strong vendors like Unite Us and Aunt Bertha, and then, of course, EHRs and national HIE. So that's the space that we're all operating in when it comes to technology, and that's what needs to be unified at this point. And so in this work group, what we'll do is we'll have conversations about what's the best way to unify. I've been having conversations with QHN and others about how that could work. I've been talking to Aunt Bertha and Unite Us and others about how that can work. And so that's the work that we will do, is bring a model together that supports this initiative, but it also is intended to support things like the OBH Care Coordination Initiative or the WIC initiatives or CDPHE functions or the HCPF prescriber tool, or aligning that with HCPF's ECQMs and other strategies that state agencies have. So anyway, I'm looking forward to having the conversation. Thanks for the opportunity to work with all of you. It's nice seeing all of you. So David, I'll turn it over back to you.
This is Stephanie Wasserman. Just a quick comment. I wonder if as a principal, there might be something where we adopt a policy that community representation is not just an activity group, but that it's there is representation in all these activity teams. So that, for example, the finance team has really strong representation from the community. policy.
Stephanie, great point. Actually, that is the intent, and it wasn't my fault, wasn't clear. The point of the community group is not to exist by itself, but to be a recruitment arm to bring community members into the other activities, just exactly as you suggested. So thank you for clarifying that.
Thank you.
Erin, would you like to describe the policy group?
Sure. Good morning. Nice to see so many faces from long ago. My name is Erin Silver. I am a recovering lobbyist who spent 20 years at the state capitol and have since gotten my parole papers and now working on projects that are close and near and dear to my heart. And this is one of them. And so in working with David and others, we are going to look at the policy and alignment functions to make sure that this work is sustainable over the long term, taking into consideration the ample opportunities right now the state has if it's redesigning mental health, early childhood education, other areas of alignment where this work makes sense to integrate into. Also looking at the increase in federal funds that are being provided to maintain much of that work and how we can insert ourselves into those conversations, as well as to educate policymakers and legislators and others about the need for the systems that Jason just talked about and the other work Kyle has discussed. And then also looking at ongoing development, fundraising, other entities that will help support this group moving forward in the long term. So if any of that sounds interesting or compelling, we hope that you can join the policy and development, and I think communications was stuck under us too, so.
Yes, it was. What we have in the process of developing kind of detailed questions for each of these groups, which will expand as the groups expand, developing budgets for each of them and pursuing resources to support them. The idea is to have supporting groups at the state level, supporting local initiatives that are converting this into the flavors that the local leadership decides are important and want to pursue. But each of these areas has a statewide component to it. And our hope is that we'll figure out properly, working with community leaders, is what the appropriate balance is between what needs to be local and what is most efficiently done at the state level. One of those key areas is workforce. And Lynn Jones is leading a group with Sarah Lampe over at Trailhead Institute to address that. Lynn, you want to talk about that just a second?
Thanks, David. And gosh, this is an amazing group. It's so exciting that we're taking these next steps. I currently work with the family medicine residency programs in the state, and as part of trying to recruit a diverse and representative workforce, I have got engaged with CCR to look at the community level and how we train allied health professionals and paraprofessionals in their roles, and then offer the opportunity for them to build their own capacity so that they are building the capacity of not only their families, but the economy of their community. So, looking at those entities that are involved in employee healthcare training. And Sarah Lampe has done a lot of work in this area from the public health perspective, taking those learnings and the good work we from the Colorado Workforce Development Council is on this call today. There are a lot of things going on workforce-wise that need toggled together in a more meaningful way. And that's what we're hoping to do, reduce barriers at the system level so that we're engaging individuals and communities in building their capacity to develop and take on career pathways and pipeline.
Very good question was asked, is what is the North Star and how do you measure that? And the group that's focused, that we're not starting immediately, but will become essential, is if you don't change what you're trying to do, you will keep doing the same thing. And so the change of what we're trying to do is much more towards thriving and prevention rather than fixing people when they break. and measuring that, figuring out how to commonly measure thriving so that we can turn the payment systems towards supporting that activity. And there are a lot of pathways to climb that mountain, but first we have to define that mountain. So there will be a group on metrics and common measurement evaluation, as well as one on if we do this kind of a common system where there's a real focus on families and what families need and integrating the support services and systems from the community, not just providers, to support them. That allows the individual professions and individual services to operate in a different way, to really operate as some of us say at the top of our license, although that's not the term for everybody. But public health, for example, has been hammered for the last year and a half. But just before that, they were thinking about a new future called Public Health 3.0. So hopefully what will happen here is enabling that kind of activity. And we're delighted that Kara Bradbury, Peter Mineta from CalFO, the Public Health Association, and Trailhead Institute at the state level are part of this. Kara, do you want to say, or Peter, do you want to add a word?
Sure, I'm happy to jump in. Thanks, David. Yeah, it's great to see you all. I know many of you from work that I was previously doing at the Office of eHealth Innovation, but recently took the role of the Executive Director for the Colorado Association of Local Public Health Officials. And as David was saying, right before the pandemic, there was a lot of work being done under this umbrella of public health transformation. And some of you may know this, or this may be new to some, but the local public health agencies and a broader group of stakeholders work together to redefine what are the core public health services, and took that to the State Board of Health and had that approved in 2019, and added some additional aspects to what was defined as the core services of public health that included social determinants of health and health equity. And then from there was on a path to really evaluate what is the gap, and completed a pretty exhaustive needs assessment of what's the gap between current state and public health and our North Star, which is really the equitable and full implementation of these core services across the state. Because right now we know that these services vary depending on where you're at in the state, and acknowledged in that needs assessment that there was some pretty significant gaps in funding to make that possible, and was kind of on this pathway of trying to identify what our roadmap was in public health to transforming what these core services look like. And then obviously the pandemic hit, and public health, as I think David said, had gotten pretty battered over the last two to 18 months, almost 2 years. And so, and now I think, when I go back and read these reports and learn about what was determined, a lot of it holds true, but some of it even more so now. And workforce, and we've had a huge loss in our intellectual capital in the public health space from people leaving their jobs and going to other fields. So workforce, the pipeline for workforce is incredibly, is a huge need. Funding, still a significant need, although the state line item for public health did double. It's, still a big area of gap. And then there's other things like data that are priorities in the public health space. So we're really excited to, we're kind of coming up with some new terminology for this work, whether that's reimagining public health or rebuilding public health. There's many conversations happening nationally that we intend to align ourselves with. So I don't know if we've landed on the correct adjective or verb or whatever combination of English language we're going to use to describe what we're doing, but we're excited to think about how the rebuilding of public health aligns with this initiative. Thanks, David.
Thank you very much. I should mention that I think all of us are aware of the vast disparities in our systems, disparities in process, disparities in access, and most important, disparities in outcomes. We've been talking about North Stars. One of those is identifying what those are and fixing them. That's what gets me up in the morning, and I know from most people on this call. And I think we know that marginalized families and individuals don't typically have a single problem. They have a collection of issues that they need help on. And sometimes it's from the public health and primary care. Sometimes it's led by, it's substance abuse, and sometimes it's housing linked to other factors. So integrating all of those is at the core of this for that purpose. Leslie, you've been in the trenches here for a very long time. Would you like to say a word about what you're doing here and what we should be doing here?
Oh man, I don't know. I think there are too many people who do this work already, who are experts in this work on this call for me to say anything groundbreaking. This is, as you know, work that we have been doing in Northern Colorado for a long time. We look forward to being in dialogue and in community with all of you, and in sharing the work that we've been doing, and in learning from all of you, and in growing this model, and hopefully, scaling it, or if there are things that can be learned from what we have been doing and from the partnerships that we have been building, we are super excited to be able to do that. So I don't know, was that helpful, David?
Well, just talking to you and Mark and the other people in your team has been extraordinarily helpful. So we look forward to it going forward. One of the points we haven't stressed is that this is intended to be a public-private partnership. We are really proud of the state we focus on, and proud of the public servants who work for it. And the intention is to have partnerships at every level in every agency of bringing into this as full partners the people in the state. And there are a number of people who work for the state in key areas who have been advising us and helping us go along and build on that. And I just wondered, Gabrielle, if you have any comments you'd like to add.
Thanks for the invite, David. I think this is a fascinating conversation and really genuinely exciting. Kara's right. Public health has sort of been back on its heels for a variety of reasons in the last 15 months. And prior to the pandemic, there were all kinds of ideas bubbling up in the field around public health 3.0 and about transforming public health in Colorado. And Mark Ernest has a question in the chat around, does success mean more money for healthcare? Does it mean more money for social services? And I think fundamentally what we need right now is money for an infrastructure, which really in some ways is sort of neither social services in terms of direct services and financing and funding for that, or healthcare in terms of direct services for healthcare. It's really about building a local infrastructure at the community level. And we'll have to think about how we define community, because people live in multiple communities, and communities can be geographic and otherwise. But what really needs to happen is there needs to be some kind of mechanism for community voice. And so, Bev's point about involving community in all these work groups is really essential. My research on doing social determinants of health just keeps coming back to the central idea that you can't just involve the community, you can't just ask the community, you have to center everything around the community. And we can have ideas that we can bring to the community, but ultimately the communities have to pick and select from what we offer them, where they want to begin, where they want to focus, and how they want to tackle certain problems. And so what we need right now is money to fund an architecture of the great thinkers in this room, sort of designing a system that facilitates dialogue at the community level and decision-making, and then starts to apply infrastructure resources to sort of facilitate the creation of the kinds of solutions the communities identified But then fundamentally on the macro level, we need to sort of remember that there is a statewide dialogue about how to allocate resources. And we need to also be involved in that statewide dialogue and that statewide macro level argument about the benefits of family medical leave, the benefits of, basic income, the benefits of, job programs, the benefits of early childhood education. All of these things are really critical. The benefits of an adequate food support system, housing security and housing stability, and low-income available housing and sufficient low-income available housing. All of these things sort of have to be involved in, and we need to make sure we're contributing to that conversation. But I sort of think of it as the first order and second order problem. Mark's question is really about a second order problem. The first order problem is how do we build sort of an institution of community voice to influence policymakers, to get policymakers to realize that communities have genuine needs, which if they start to meet those needs, can actually change the trajectory potentially of the expenditures on a lot of programs that work at a programmatic, more direct level. So I think this is a great project and super excited to watch it move forward, and so impressed by the number of people and the people who are on this call, because I know so many of you and I'm so impressed by so many of you. So thanks, David, for pulling this together.
For those of you who don't know who he is, Gabrielle runs chronic illness programs and related things for CDPHE in the state, and has been at this for quite some time.
David, Roger here. Can I make a comment?
Please do.
I think that one of the fundamental challenges is this program is arguing for a really major shift in perspective. Most of the work that's been done is top-down work to communities, i.e. programs, providers, policies to communities. It has not generally been user-focused design as the core principle. And that's where I think we have to make the difference. Whether it's services to people and families or informatics, we can't say, well, this is what we will give you. This is what, these are some of the user pieces that we've designed into this. It has to start completely at a 180-degree difference. What are the needs of the individuals in the communities, and building this infrastructure around those needs rather than building the infrastructure down to the people, if that makes any sense.
One, I agree with you. I believe that what Mark Kling is, Mark, why don't you just say for the group what you're starting to talk about in the chat?
I think it's been a great discussion, and I think that's why we're here together, is to hear stuff like this. And I just made the point that
Mark, would you say who you are first for those who don't know you?
Yeah, I'm executive director of the Family Resource Center Association. We have 33 family resource centers that use comprehensive coordinated case management to provide families with whatever services they might need to become more self-reliant. And my point is that I agree that some of those dollars need to move to social services, but the focus of this group is making sure that those social services are coordinated and that they don't stand in silos. Because what the system has a tendency to do is select some siloed social services for funding, which one can argue means other services are not being supported. And what we need to do is aggregate those and provide those to the services that the families need. And I think there's been a great discussion so far about listening to families about what it is they need instead of deciding for them what it is they need.
Thank you. Well said. Back to Mark Ernest's point, I think fundamentally we can look at where we spend money in our society. We spend an enormous amount of money when people fail. We will jail them, or when they get really sick, we'll do lots of operations on them. But as one of you said, the first order problem is to establish the common infrastructure for integrating services like Mark talked about. The finance issue is fundamentally flipping that investment equation to invest in thriving and in prevention so that we're not spending on failure. And I think in looking at where we spend health dollars, 5 or 6 cents on the dollar goes into primary care, and 2 or 3 cents goes into prevention, and the rest goes into when people specialists in acute, and we need to reverse that. John Peters, who I'm delighted is here. If you don't know him, he is, well, John, you can say who you are, but the answer to your question is yes, we have money in the budget to have Glenn Mays and his team over at the Public Health School create a complex adaptive systems model underneath this, so that community after community can model how their particular decisions to spend more on food or a daycare center, whatever it is, how that would play out in the community. It's something that Don Neese and Glenn Mays and I have talked a lot about, and we think is an example of the kind of tool at a statewide level that could empower localities to make different kinds of choices and see how they would play in the and as Peter Mineta is pointing out, Daniel Varda and the folks at Visible Networks are all about putting empowering families to go forward. Dave Keller, you have your hand up.
Yeah, I just want to say that I think it's important that we need to remember that the measure of investment is both a symptom, if you will, as well as a cause of the problem. I mean, I think we need to invest in the infrastructure and, to Frank's earlier point, the collaborative infrastructure that's necessary to create the kind of system that we're talking about. The fact that our current spending pattern is what it is, I think of as more like a thermometer. It's a sign of what's going on. And just like treating temperature without treating the underlying cause gets you nowhere in treating a patient with illness, focusing too much on that without really building the right infrastructure and really focusing on developing a system that looks at the community as a whole, that is embedded in the community and that can respond to the needs of the community without the top-down approach that we talked about before, is key to changing that measure. If we just change the measure, if we just throw the money in a different pot, then we're going to end up with a different set of silos with different sets of priorities. And we just need to stay focused on that. It's not just about shifting the money. It's about shifting the way we use that money too.
Absolutely. We're almost at time. Are there others who would like to speak up, to add to the comments? And let me just stress, this is a living project. It's a work in progress. Somebody asked me the other day if everything was baked, and I said no. The oven is being turned on, and we're working at the counters. So if others want to speak up, please just open your mic and do so. Oh, come on. I've been on the phone with you guys. I know this crowd.
I'll add something just to say that I think that, given the urgency of the conditions that we've all been describing here, that these efforts have to be health promoting in their own right when they happen in communities. So not just the improvements that are made to the structures and systems and care coordination in those areas, but the improvement that they have to be intentional about improving collective efficacy at those levels as well.
I agree, and I think it's worth keeping in mind at every step that what the natural outcome is to these kinds of discussions. The natural outcome is to fund another program or to expand the program that's addressing the problem. So there is a severe behavioral health program, health crisis in the state. So the most natural thing to do is to spend more money on it. And in many ways, that's the right answer. But as Gabrielle pointed out, taking some of the funding just as and using it for the common infrastructure behavioral health people have physical problems, they have social issues, they have housing issues, they have transportation issues, and that's really what we're talking about. Anyone else want to add anything? Otherwise, we're going to go back to Frank to wrap it up for us.
So David, Christy just put something in the chat that I think you have some kind of response for about next steps and
yes, what there will be an overarching group, though I'm not sure I like the word, Christy, because this is really a collaborative effort. But the leaders of each of the activity teams will be meeting regularly to try to keep coordinated, but more importantly, to reach out to the leaders in the state. I mean, for example, take IT. Jason already has a team, and we're expanding the team, but he's already working with an incredibly smart, thoughtful woman named Carrie Pycoach, who's leading OHI. So there's people in government, people like Camille Harding and others are really thinking about how to have new kinds of whole care networks. And so we will have a coordinating effort, which we're trying to budget and fund to keep this all collaborating and to do the kinds of things Frank described at the beginning. Exactly how to do that, Perry Dickinson, who's been on this call, gave us a model for that with a recently terminated project of running a collaborative effort in the state with a lot of groups. And so we're not suggesting the university run this project. We'll be one partner with others in trying to do it going forward. But as Frank said, there's a tendency, somebody said the other day, there's a tendency to think that collaboration doesn't need to be funded, that collaboration is just something people do. But collaboration is hard, and it takes a lot of time and a lot of effort and learning how to listen to other people and that their words, they use different vocabulary than we do. So as Frank said at the beginning, we intend to spend a lot of time on trying to figure out how to institutionalize that and make it a much more natural thing to do.
Hey, David, this is John. Real quick question. Has there been any discussion of any particular communities in Colorado that might be ideal as lead communities to show how this sort of model can work at a community level to provide kind of the beacon of, if we do this, it actually works?
Yes, and what we're hoping, I should have addressed that. Thanks for raising it, John. Yes, a lot, and I'll let a couple of them speak for themselves. But the idea here is to have that going forward on a parallel track with them learning as we're learning and sharing ideas back and forth, so that we're doing kind of rapid innovation going forward. But Leslie, you want to add, just respond a little bit, and then maybe. I think Sharon, if Sharon's still on the call, she might address that, or Glenn.
Sorry, can you repeat the question? Respond to which?
What John wanted to know, if there were communities already moving in this direction who could show the benefits of, if they got more resources, how that would make a difference. And I think you might know a little bit about that.
Oh, man. Yeah, so I mean, I guess, feel free to poke holes in this, but I think we have built in Northern Colorado in partnership, the Alliance has built in partnership with Sunrise Community Health, with our local community mental health centers, with a variety of other partnerships, and incredible infrastructure for community-based agnostic care coordination. Through a variety of braided funding. The core of our work is around our Medicaid population, supported by and funded by our RAISE. And that, obviously that's a Medicaid population, and that is structured by the billing requirements, et cetera, of funding source. And if we had sort of unrestricted dollars, there's a ton that we could do. Specifically, we struggle sometimes to ensure that we have a funding stream that will allow us to buy, interview clothing for people, struggling to make sure that we have available for our folks experiencing homelessness, dry socks and a variety of other refrigerators for people who just got an apartment. So with expanded funding, I think there is an awful lot that we could do to enhance the work that we're already doing. Does that help to address?
Yeah, and I think there's a lot of lessons learned there where they've driven this bus as far as you can, almost, or as far as you can down the road of the current system. And if we could kind of change the current system so it supports what they're trying to do up there, that would answer your question. I think that there are other communities around the state where there are wonderful leaders who are coming together and have partnerships that may not include everybody, but include a lot. And so the idea is to build on that in the Roaring Fork Valley. We've talked to a bunch of people there. Sharon Raggio was on the call, and the West Mountain Health Alliance we've been talking to. So, and we have in a budget funds to compensate community leaders from those groups for participating in these discussions as well. Sharon, would you like to add a word?
Thanks. I would just say, yes, we are in deep conversation. We have had some models that were very successful. We had a community health worker model that I think was very successful in the Roaring Fork Valley and other communities as well. That again had was agnostic as to who they were helping or what organization the person belonged to, but really had a big focus on social determinants of health. And funding will help, because regrettably that funding went away and it was not sustainable. We are in other conversations about how we help our homeless population in the Roaring Fork Valley. What does that look like? As well as something I will say I'm particularly interested in, which is some of the new information coming out from many sources, as well as the CDC, with respect to suicide, and how more suicides are really linked to social determinant of health kinds of things and social isolation, more so than a person having a mental illness or something like that. So I think there's lots of opportunity to get more upstream. I love the prevention focus and look forward to learning more.
Okay, and Leslie, go ahead.
I was just gonna, appreciate one more crack at this. We have developed a care coordination team. It's speaking to the evidence that says, is this successful? In our Coast Law team, which is our care coordination team dedicated to folks experiencing opioid use disorder and other substance use disorder, we have been able to demonstrate multiple improved outcomes being able to deliver this agnostic care coordination team. And of course, that is grant funded. And whoever was speaking at the beginning about not wanting to do another hand-to-mouth grant cycle, that is absolutely what that was, but and is, we had a 3-year grant, now we have a 5-year grant, but we have been able to demonstrate improved anxiety and depression, improved attainable housing obtained, employment obtained through this care coordination system. So yes, we have that data, and with sustainable funding, we could continue those successes.
The bane of our existence, Zoom, means that we all have meetings that go noon to 1 or 10 to 11. And so people need to go, and respecting people's time. Thank you for being here. We're going to close it off now, but we look forward to working with you. Thank you for your time and your interest. And please, if you have an issue, let us know. There's no... we all need to learn to collaborate, and I'm more than others. So please be active.
The only thing I'm still not clear, how do we sign up?
I'm sorry, send an email to Linda Niebauer or me saying which one you want to be part of. And there are a number of links there.
And
Thank you,
Kyle
folks.
also put a Google Doc in there that would allow you to sign up as well.
Yeah. And
Oh, we'll put that in a follow-up email because I'm going to lose it as soon as we lose the Zoom.
Okay,
Yeah,
guys.
will you send out the recording in the chat, please? That would be helpful. Thank you.
Thank you, everybody. We will do that.
Linda, I can,
Thanks,
yeah, you're welcome. It just seemed to make sense to me, instead of you getting 30 or 40 individual emails or them going to you, David, or the individual group leaders, to have a centralized form or document. And it took 5 minutes to put it together.
And see, I've never done anything like that particular one. Does that mean that I can easily access then?
I can give you access to
Okay.
it pretty easily. So let me first I'll send you the link.
Okay.
I mean, if you could also copy it over from the current chat, but I'll just send you an email with the link, and then I'll share with you permission to like see the responses and all of that.
Okay. Yeah, I was copying and pasting a Word document that has all the chat in it. So I've got that. I just need, I just need to kind of get my arm around this with David. I kind of come in, not in the middle, but I'm sort of flying by the seat of my pants to catch up. So I
feel
appreciate your help.
Yeah, let me know how I can help you in that. I'm happy to help kind of coordinate and be that bridge too.
Perfect. Thank you.
All right.
Have
Take
a
care.
good one. Bye-bye.
Bye.